Hello, everyone. We are on day 90 out of the 90-day free NCLEX review series. And we are also inviting you to enroll to our NCLEX review at stankosnclexcoaching.com. And today is our final day of the series, and we'll be tackling on the topic of sepsis. So I want you to really prepare with your notes and your pen so that you can jot down all those important concepts that we'll be discussing. So let's get started. Our first question we have is to help prevent the onset of systemic inflammatory response syndrome, or SIRS, in hospitalized patients, which nursing interventions are most appropriate? Select all that apply. A. Administer antibiotics promptly within an hour for patients suspected of sepsis. B. Ensure early ambulations for post-op patients. C. Discontinue urinary catheters as soon as they're no longer necessary after surgery. And D. Apply strict aseptic technique when handling invasive lines or equipment. And letter E. Advocate for parenteral nutrition if patients have inadequate caloric intake. This is a select all that apply, so make sure that you pick all those important nursing interventions. Now, please don't forget to join us. Put your answers in our chat box or in the comment section so we'll know who's actually participating. So the correct answers in these questions are the following. We have letters A, B, C, and D. Why letter A? Administer antibiotics promptly within an hour for patients suspected of sepsis. The timely administration of the anti-infective or antibiotics can reduce greatly the likelihood of sepsis progression into what we call as SRIS, or what we call as SIRS. Now, if you selected letter B, that's one of the correct answers as well. Ensuring ambulation after the surgery can prevent infection, which can contribute to the SIRS as well. Now, if you selected letter C, that's also correct. Removal of those catheters can actually limit the infection risk, and this is also a very important step in preventing the SRIS. And also letter D, apply strict aseptic technique when handling invasive lines or equipment. You should be doing the strict aseptic technique or sterile technique when you are working with those procedures, sterile procedures, or invasive devices. When you are doing the dressing change for the central line, if you are changing the tubing for the TPN, or when you are simply changing the tubing for the IV fluid, those are important steps to prevent the sepsis. Okay, now why not letter E? Advocate for parenteral nutrition if patients have inadequate caloric intake. Well, we know that if they have inadequate intake, that is something that we need to be concerned about. But what is actually recommended here is to use enteral nutrition. That is much more preferred compared to using parenteral nutrition, or TPN, because it has more. I mean, the use of the TPN has a greater risk involved in the development of sepsis. Okay, a lot of avenues where infections can set in. So you really need to prioritize the nursing actions here that can prevent the infection. So again, these are the options: A, B, C, and D. Wonderful. I'm seeing answers here, all the 4 correct answers. For those who just join us, thank you. And yeah, feel free to put in your answers while we're going to go through the questions. Let's have our next item. Number 2, when evaluating a patient for early signs of septic shock, which symptoms should the nurse look for? A, high blood pressure. B, flushed, warm skin. C, cool, clammy skin. And D, signs of hemorrhage. We're talking about early signs of septic shock, not late signs. The correct answer here should be letter B. That is flushed, warm skin. The reason for that is because during the initial hyperdynamic phase of the septic shock, the patient here will have that vasodilation and also an increase in the cardiac output. We're talking about early phase, not late. So the correct answer here is the flushed warm skin. The reason for that is because of the vasodilation and increased cardiac output, not letter C. The cool clammy skin is something that you can associate it with the later stage of septic shock. This is what we call as the cold phase. And if you selected letter A, high blood pressure, well, generally, the patient should have normal or lower blood pressure during the early phase of septic shock, not higher blood pressure, generally. Now, if you selected letter D, signs of hemorrhage, this is not typically seen in patients with septic shock. So be careful when you are going to be asking this type of question. Take note of the clue words, early or late. There's huge differences in the manifestations of shock within those two different phases. Let's have our next item, number 3. For a patient with a toxic shock receiving ceftriaxone, Urosepsis 1 gram every 12 hours, which lab values should the nurse closely monitor along with culture and sensitivity tests? A, arterial blood gases, B, serum osmolality, C, spinal fluid analysis, D, serum creatinine. We're talking about monitoring about the culture and sensitivity tests. So what would be that? Along with culture and sensitivity test, we are treating this patient with Urosepsis or ceftriaxone. Your answer here should be letter D. Why letter D? Well, in a patient with a septic shock, there is going to be a reduced blood supply to the kidney. This will impair the excretion of the antibiotic ceftriaxone. So there is a potential that this medication can cause toxicity. So what you need to do here is to check the patient's serum creatinine. This is very important. Along with the serum creatinine, you need to take a look into the other renal function, which will help you identify if there is any problem going on in the kidney, especially that there is reduced blood flow to the kidneys in this case, toxic shock. All right. So again, the main exit point for this medication are the kidneys. Okay, or exit point is the kidney. So make sure that you're going to have to look for that lab value that will give you an idea. Hey, my patient's kidney is no longer working right now, or maybe my patient is progressing into acute renal failure. So you got to take a look at those serum creatinine, BUN, and also serum creatinine clearance as well. All right, or if there is GFR, much better. Now, why not letter A, arterial blood gases? This will be primarily used for acid-base imbalances and not really a concern in this scenario. We don't have anything that supports the need for ABG this time. Now, if you selected letter B, serum osmolality, which is basically going to tell you the concentration of your patient's blood. Okay, remember about the concentration, it can range from 270 to 300 milliosmoles per kilogram. Take note of that. Serum osmolality will tell you how the blood is diluted, or is it so concentrated, or it's just within the range. Okay, so take note about that value. Now, letter C, spinal fluid analysis. This is relevant to central nervous system infections, not toxic shock. All right. So what you're going to need to look for here again is the laboratory data that will help you look for any signs of impending impairment of kidney function. And that's letter D, serum creatinine. Alrighty, let's have number 4. Which condition might develop as a serious complication from septic shock? A, COPD. B, mitral valve prolapse. C, anaphylaxis, D, acute respiratory distress syndrome. What is your answer here? Serious complication from septic shock. The answer here is letter D. That is acute respiratory distress syndrome, or known as ARDS. This is something that can occur to your patient even after the septic shock has been controlled. This is a very known complication to sepsis or septic shock. Well, why is this going to happen? The reason for that is because when there is septic shock or sepsis, there's going to be that overwhelming infection. That widespread infection in the bloodstream can actually trigger the body's immune response, and the body will have to release those large amounts of inflammatory chemicals. And these inflammatory chemicals can circulate into the bloodstream, and this will lead to what we call as the SIRS, right? Systemic Inflammatory Response Syndrome. Now, when these inflammatory substances are released into the circulation, this will make your blood vessels permeability much more increased. So this will allow the fluid in the vascular compartment to leak into the interstitial spaces. And if we are talking about capillaries in the pulmonary circulation, this can allow the fluid to leak into the lung tissue and into the alveoli. And so the patient here will end up with the crackles, fluid inside the lungs, and this can really drown our patient. This can lead into the drop of their oxygen levels. The patient's partial pressure of oxygen will drop. Your patient's oxygen saturation via pulse oximeter will also drop. And so your patient will have that respiratory distress. There's going to be tachypnea, difficulty of breathing, and our patient really will need immediate attention when they have this ARDS. Why not letter A, COPD? Well, this is unrelated to the acute septic shock complication. And if you selected letter B, mitral valve prolapse, this is a heart valve issue that is not a result of septic shock. And letter C, anaphylaxis, is another type of shock, but it's not a result from septic shock. Okay. All righty, let's have our next item. Number 5. 3 days after a central line was placed for chemotherapy, a patient presents with symptoms including difficulty of breathing, inflamed central line site, blood pressure of 82/35 mmHg, heart rate of 135 beats per minute, respiratory rate of 26, fever, temperature of 104 degrees Fahrenheit, 40 degrees Celsius, and oxygen saturation of 86%. After alerting the rapid response team, what should the nurse do next? A, set up a peripheral IV line and administer normal saline. B, administer an antipyretic as prescribed. C, apply cold compresses to the patient's head. And letter D, attach the patient to a portable ECG monitor, or what we call as the continuous cardiac monitoring device. What is your answer here? Your answer should be letter A. No other than letter A this time. Why? It is very important that our patient has an established peripheral IV access and immediately start the normal saline solution to allow the blood pressure to increase, to improve the blood circulation and also the volume within the bloodstream. That is the first action that you should consider, because the issue here is circulation. We want to replenish what is lost in the bloodstream. Remember that with the increase of the inflammatory substances in the bloodstream, this will allow the blood vessels to become leaky. It will allow the fluid to shift into the third spaces. So our patient will become hypotensive. We need to keep up with the low blood pressure. Make sure that you're going to replenish it right away. So you're going to expect that your patient will be receiving boluses of saline solution in this emergent period. All right. If you selected letter B, administer an antipyretic as prescribed, this is important, but you need to do the fluid resuscitation first. That is the priority. If you select letter C, apply cold compresses. This will help with the reducing the fever, but again, this is secondary to fluid replacement. And for letter D, attach the patient to a portable ECG monitor. This is useful, but it will not address the immediate need for the circulation support. You need to maintain the adequate perfusion to the vital organs. Take note of that. If your vital organs are not going to get the adequate perfusion, they're going to start to fail within a few hours. So that's something that you should consider when your patient is in sepsis. It can happen really fast, no kidding. Let's have number 6. Which patient should the nurse prioritize for care after change of shift report in a progressive care unit? A, patient with a spinal cord injury at T5 a week ago who has a heart rate of 54 beats per minute. B, patient who had an inferior myocardial infarction 2 days prior and has long crackles at the bases. C, patient admitted with anaphylaxis 3 hours ago and now stable with a blood pressure of 108/58 mmHg. And letter D, patient with suspected urosepsis with pending orders for urine and blood cultures and antibiotics. Your answer, please. Well, the correct answer here is letter D. Why letter D? Because patients suspected of having sepsis, they should receive the antibiotics within an hour. And this is to help prevent the development of severe sepsis and SIRS. All right. If you're going to delay administering the medication or the antibiotic, this can worsen their condition. All right. Now, if you selected letter A, patient with a spinal cord injury at T5 a week ago who has a heart rate of 54 beats per minute, 54 is low, right? But it generally does not require immediate intervention this time. If you selected letter B and now has a patient that had MI 2 days ago and now has long crackles in the bases, that is significant change. This is something that can happen in a patient after they have an MI. But this is not as critical compared to the patient or the option that we have in letter D, which is basically the sepsis, circulation issue, perfusion issue. Letter B, crackles at the bases, it's not really giving us enough information if they are desaturating or decompensating. No information about ABGs. There's no distress. Of course, this patient needs attention, but it's not as critical compared to our patient in letter D. If you selected letter C, patient admitted with anaphylaxis 3 hours ago and now stable with a blood pressure of 108/58 mmHg. The word stable with a blood pressure of 108/58, yeah, this patient doesn't need to be assisted right there. I mean, right now, we have to prioritize this patient that is in letter D. Okay, so what you're going to look for in this case scenario is to find that patient that has life-threatening complications, possibly. Okay, so you need to make sure that you can assess this first, and so you can administer those necessary treatments, such as antibiotics. All right, let's have our next item. We have our number 7. A patient with gram-neg sepsis has a temperature of 101.2 Fahrenheit, blood pressure of 90/56 mmHg, pulse of 92 beats per minute, and respirations of 34 breaths per minute. What should the nurse do next? A, administer prescribed acetaminophen or Tylenol. B, inform the healthcare provider of the patient's vital signs. C, administer the scheduled IV antibiotic. And D, check oxygen saturation with pulse oximetry. Take a look into those vital signs. Which of these vital signs really can be a red flag? Well, of course, that's going to be letter D. The patient in this scenario has a respiratory rate of 34 breaths per minute, right? This is way elevated. It is elevated, 34 breaths per minute. Tachypnea, that's not a good sign. Why letter D? Well, in this patient that has the gram-negative sepsis, and if they are already having this respirations of 34 breaths per minute, this is a sign of respiratory distress syndrome, acute respiratory distress syndrome. And so you need to monitor for the hypoxemia. All right, you need to intervene on this one urgently. Okay, why not letter A? Acetaminophen can reduce fever, but it will not address the respiratory concern. If you selected letter B, inform the healthcare provider of the patient's vital signs. We know that this is very crucial to let them know about what's going on. But you lack that information about their oxygen saturation. You only have the 3 values here. I mean, are only 3 or 4? The temperature, blood pressure, pulse, and respirations. You don't have any value for the oxygen saturation. You need to have that information first before calling. All right? You need to do that assessment first. Why is a patient having this respiratory 34 breaths per minute rather? So you gotta need to get that information about their saturation level. And if you selected letter C, administer scheduled IV antibiotic, well, this is important, but this can happen after you have adequately assessed your patient, especially detecting for hypoxemia, because this patient is in ARDS. Stella said, confusing now, you said we should administer antibiotic ASAP. That is correct. But in this case, our patient is in ARDS, which is an added complication to the problem. Okay? This is something that we need to address, because when your patient goes into ARDS, there are more complications that we need to anticipate. We need to treat it accordingly. So you're correct that we need to administer antibiotics, but that is going to be applicable in a case wherein maybe you already have everything needed. Let's say all the medical orders are already in place. You already have the complete assessment, okay? This has already been notified to the medical provider, so you have everything ready. Everything is ready to go. You can administer right away the antibiotic. But around this time, gram-negative sepsis is temperature. And if there is this significant respiratory rate of 34 breaths per minute, this is going to cause this patient to go downhill faster. All right? So you need to do your assessment to obtain more data about their respiratory function. Okay? Our patient is in the midst of that ARDS. All right, let's have number 8. Which patient should the nurse assess first after receiving a report on an oncology unit? A, patient with neutropenia and a temperature of 100.5 degrees Fahrenheit or 38.1 degrees Celsius. B, patient experiencing dry mouth after head and neck radiation. And C, patient concerned about timely administration of a prescribed long-acting opioid. And letter D, patient with a platelet count of 82,000 microliters post-chemotherapy. Now, review the scenario. Which of these patients should you see first? We're talking about these patients in the oncology unit. That should be letter A. Why letter A this time? Because when your patient has a fever and they are neutropenic, this is an emergency because it indicates that this patient is actually heading into sepsis. This can develop rapidly. Take note of that. When you have a patient that has neutropenia, they start developing that fever, they're going to be a priority patient this time. Again, look into the complication of sepsis. There is an active infection going on. We know about what's going to happen, right? There's going to be hypotension, widespread vasodilation. Patient is going to end up with multi-organ dysfunction if we're not going to treat this patient right away. Now, why not select letter B? Patient experiencing dry mouth after head and neck radiation. We know that this is what we have as a xerostomia. That is a term for that. This is a known effect of a radiation treatment. This isn't comfortable, of course, but this will not require an urgent intervention this time. Why not letter C? Concern about timely administration of a prescribed long-acting opioid. We know that timely administration of pain management is also important, but is there a sign that there are in immediate stress? And of course, if you are going to face these 4 different patients, let's just say you have all these 4 patients, are you going to really do this, or are you going to address this patient first compared to the patient who is in letter A? This is a high-risk patient. Now, if you selected letter D, patient with a platelet count of 82,000 microliters post-chemotherapy, this is thrombocytopenia, right? This is an abnormal finding. You need to be careful because they are going to be prone to developing bleeding. So invasive procedures can actually aggravate the bleeding. But it doesn't really require urgent intervention this time. There's no signs or manifestations of bleeding. So we're going to continue monitoring this patient, but we will deal first our patient in letter A. You need to prioritize that patient that has the active signs of infection, especially if they're immunocompromised because of their risk to developing sepsis. Alrighty. Again, letter D doesn't have any signs of bleeding. You're going to have to intervene that. Next, let's have number 9. A patient is admitted with a probable bacterial pneumonia and sepsis. Which order should the nurse carry out first? A, administer acetaminophen Tylenol as a suppository, and B, obtain blood cultures from 2 sites. C, transport for a chest x-ray, and D, administer 400 milligrams of ciprofloxacin IV. Which one will you do first before, or I mean, with all these interventions, what would you do first? The answer here is to carry out letter B. Make sure that blood cultures have been obtained at different sites. This is very important. Before you administer any antibiotic to your patient, especially in the case of sepsis, make sure that the blood cultures were already obtained before you start giving the antibiotic to ensure that we can identify the causative microorganism. We will be able to know what virulent microorganism has caused this problem. All right? So always think about performing this, or maybe other cultures such as sputum culture or maybe urine cultures. These are other stuff that probably will be required before you're gonna need to administer the antibiotic, especially in a case of sepsis. Okay. Now, why not letter A? Acetaminophen. This can alleviate the fever, but it will not address really the cause of infection. We need to identify that microorganism in order that we'll be able to administer the proper antibiotic therapy, which will really target, which will kill that microorganism. All right. If you selected letter C, transport for a chest x-ray, this is something that can wait, and you should make sure that letter B is done first. Now, why not letter D? Administer 400 milligrams of ciprofloxacin. Well, this is something that you can administer after the blood cultures have been obtained. So we will know for sure again what microorganisms caused the sepsis. Always remember that. Alrighty, let's have number 10. A patient with septicemia shows prolonged bleeding from venipuncture sites and blood in the stool. What is the priority action? A, apply dressings to venipuncture sites. B, avoid further venipunctures. C, inform the healthcare provider. And D, administer proton pump inhibitors as prescribed. Take a look into the scenario. Patient with septicemia now has prolonged bleeding from the venipuncture sites and also presence of blood in their poop. What will be your priority action here? Will that be application of dressing to the venipuncture sites? Or will this be avoid further venipunctures? Or is it to inform the healthcare provider? Or could be administration of the proton pump inhibitors or PPI. Take note that your patient is bleeding on different sites. Blood in the stool, meaning that your patient probably is having hemorrhage in the GI tract, right? Prolonged bleeding in the venipuncture sites and blood in the stool. Your answer should be letter C this time. You need to inform the medical provider right away because your patient actually has disseminated intravascular coagulation, which is a serious complication of the septicemia. All right. This should be reported right away because this will require immediate intervention. And also it will require other lab tests and possibly will require more medical provider orders. So this doctor should be notified right away. We need to treat this ASAP. Why not letter A? Apply dressings to venipuncture site. Well, we know that it can reduce the bleeding, but it will not address the underlying issue. We know. Like to take a look into the statement, prolonged bleeding from venipuncture sites. Is it saying that there is like massive bleeding, like squirting blood out of the arteries or the veins? It doesn't seem like that, right? So we know that this is very significant, right? Of course, you're going to have to apply pressure into the site, but it doesn't really take precedence compared to what we have in letter C, right? You have to make sure the medical provider is ahead of you're going to notify them ahead of time so we can get these urgent orders for lab work and other treatments. Now, if you selected letter B, avoid further venipunctures. Yes, we know that is also a good one. It can minimize further bleeding, but it is not the most critical action this time. If you selected letter D, administration of PPI, this will reduce the GI bleed, but it will not treat the DIC, the disseminated intravascular coagulation. Again, take note of this complication. This can arise when there is widespread inflammatory response in the body. All right, let's have our next item. A client with sepsis is being treated with topramycin. Reviewing the lab results, the nurse determines that client is responding well to treatment if which lab values are noted. A, white blood cell count of 14,000 cubic millimeter and blood urea nitrogen of 35 milligrams per DL. B, white blood cell count of 7,500 per cubic millimeter and creatinine level of 0.8 milligrams per DL. Sodium level in letter C is 143 milliequivalents per liter, potassium of 3.7. And we have letter D, sodium level of 144 milliequivalents per liter and chloride of 105 milliequivalents per liter. Again, take note about the stem of the question here. The nurse determines the client is responding well to treatment if which lab values are noted. And take note that the treatment that is provided to the patient is the tobramycin. Now, you need to know what this medication is. If you don't know, well, take a guess. Use the test-taking strategy as much as you can if you're not familiar with the medication. So, if you do know what this medication is, and if you know that this medication can do this and that and the possible complications, then you should select letter B, which is white blood cell count of 7,500 per cubic millimeter and creatinine level of 0.8 milligrams per DL. Now, let's identify what tobramycin is. This is an antibiotic. It is classified as an aminoglycoside antibiotic. So what is the action of this medication? It will disrupt the protein synthesis in the bacteria. We know that the bacteria has to do this protein synthesis to cover itself, its cell wall, to prevent it from dying. But the medication actually will disrupt this synthesis. So it will cause bacterial death. Now, what this medication is intended for, this is going to be used for those gram-negative bacterial infections such as Pseudomonas aeruginosa. However, when we are going to administer this medication, this is nephrotoxic. It can also be ototoxic. That simply means that this medication can cause harm to the patient's kidneys. It can also cause hearing issues. It can also have that the patient probably will encounter issues with balance because it can impair the cranial nerve number 8, right? And also the kidneys will be somewhat kind of be impaired when you are going to give this nephrotoxic medication. And so in order for us to determine that this medication is safe and effective at the same time, we need to look for those lab values rather that indicate that the white blood cell count is within the normal range. It simply means that we are actively treating, or the medication is effectively treating the infection. 7,500 per cubic millimeter is within the normal range. That's very good. Creatinine level of 0.8 is within the normal range as well. So that simply means that the patient's kidney function is stable. Now, if you selected letter A, white blood cell count of 14,000, this is elevated white blood cell count. And the blood urine nitrogen of 35, that is also elevated. This is a significant finding that the patient may have a renal impairment, and your patient's infection probably is still not treated as of the moment. This is an active infection going on, elevation of a white blood cell. And if you selected letter C, sodium of 143, potassium of 3.7, yeah, these values are within the range, but these two do not reflect infection response. It doesn't reflect effectiveness of the tobramycin. It doesn't reflect the effect the kidney function as well. So we're going to eliminate that. And the same thing with letter D. You need to eliminate letter D again because it will not give you an idea that tobramycin is effective against the bacterial infection, and it does not give you an idea if the kidneys are impaired or not. All right, so go back into your basics in understanding signs of the creatinine, the kidney function, and also if the white blood cell count is within normal, or if it's high, or if it's too low. You got to review those concepts as well. Now let's have number 12. Which of the following clinical signs support a diagnosis of sepsis? Select all that apply. A, mean arterial pressure of 65 mmHg. B, hypoactive bowel sounds. C, temperature of 102 degrees Fahrenheit or 38.9 degrees centigrade. Or D, systolic blood pressure of 110 mmHg. E, heart rate of 96 beats per minute. And F, urine output of 50 mL per hour. You're going to select here those clinical signs that support diagnosis of sepsis. What are your answers here? Your answers should be letters A, C, and E. Okay, why letter A? Mean arterial pressure of 65 mmHg is actually low. Anything below 70 is already a criterion for sepsis. Anything below 70. Let me repeat that. Oops, let me change my stuff to a pen. Hopefully, this is going to work. Less than 70 MAP. That's already a criterion for sepsis. Okay. Now, what is the MAP, or the mean arterial pressure? So I hope that you still recall this, because I've already discussed this in the previous sessions. The MAP is our determinant if the body is able to provide adequate blood flow to the vital organs, the peripheral body organs. And so if the value is less than 70, it simply means that the body is no longer able to provide adequate blood supply and oxygenation. All right. Now, how do we obtain the MAP? Well, the formula for the MAP, where's my, okay, here we go. The formula for the MAP, you still remember this one? That's actually multiplying the patient's diastolic blood pressure by 2. And then you're going to add it by the systolic blood pressure over the constant number of 3. So this is how we calculate the MAP. Now, for example, if the patient's blood pressure is 95/40, we'll associate or substitute these values here. So you got multiply the diastolic blood pressure of 40 by 2, and then you're going to add it by the systolic blood pressure of 95, constant number of 3. So what is that? That's going to be what? 80. You're going to add it to the 95 and then divide it by 3. So your answer here will be what? That's going to be 58.3. This is critically low. All right. So your patient is very at risk in this case scenario, less than 70. Question from Petra, but normal heart rate is 60 to 100. Why is 96 a sign of sepsis? 96 is actually one of the given criterion in the sepsis. Okay. Anything that is higher than 90 beats per minute in the current sepsis criteria, this is a signal that your patient is actually in that complication already. We know that in our fundamentals of nursing, 60 to 100 is within the normal range. But if you are actually taking care of a patient in sepsis, anything above 90 is actually considered a progression into a septic shock. Take note of that. We are talking about the criterion of sepsis. This is an established value that we should follow. All right. Now, let's have our other items. Hypoactive bowel sounds. Do you think hypoactive bowel sounds will be one of those? Of course not. This will not indicate sepsis. All right. This is not this is not included in the criterion in sepsis. Even though if it may indicate that there could be some issues in the GI tract, but it doesn't really signify that there is paralytic ileus. Hypoactive bowel sounds can come and go, right? But it doesn't really signal that there is paralytic ileus this time. Now, what about letter C? Temperature of 102 degrees Fahrenheit, 38.9 degrees Celsius. That's part of our criteria. Any temperature that is above 100.9. Please take note of this. Any temperature that is above 100.9 degrees Fahrenheit or anything greater than 38.3 is also part of the criteria. Okay? Now, if you selected letter D, systolic blood pressure of 110 mmHg, this is incorrect. This is within the normal range and it doesn't indicate hypotension. If you selected letter F, urine output of 50 mL per hour, this is incorrect because we know that our urine output should fall between 30 to 50 mL per hour. It does not indicate that there is a decreasing urine output. So we are going to eliminate that. So again, our correct answers should be the following: A, C, and E. These are included in the criteria. Alrighty, please take note of that. The 90, anything above 90 is already a sign your patient is in sepsis, especially if we're talking about sepsis. Let's talk about number 13. Which client is at the highest risk of developing DIC? A, 44-year-old with a pulmonary embolism. B, 80-year-old diagnosed with septicemia. C, 62-year-old undergoing hemodialysis 3 times a week. And letter D, 34-year-old pregnant with placenta previa. I've already mentioned this earlier. You're welcome, Ruth. The correct answer here should be letter B. This is the 80-year-old diagnosed with septicemia. Remember that with sepsis, this can trigger that widespread release of the inflammatory substances. This can also release, or it can trigger, that coagulation system, especially the tissue factor. Remember about the tissue factor, which is actually one of the early tissue factor. This is something that can be activated once the widespread inflammatory response has been activated. This can be released. I'm talking about the tissue factor. This is going to be released from the damaged tissue caused by the decreased tissue perfusion, right? Now, what's going to happen when the tissue factor is released? This will now lead to the development of those small clots in the blood vessels. This can cause blockage of blood flow, and this will further cause damage into the tissues. Now, remember that this is widespread, right? It will lead to overconsumption of the clotting factors. So there's going to be more clots that's going to be forming actually, and this will use up the platelets, right? So the platelets and the clotting factors will be used up in greater amounts, so your patient will have a very difficult time in stopping their bleeding. Now, what's going to happen aside from that? There is what we call as fibrinolysis. Are you still familiar with this? This is part of your DIC. Disseminated intravascular coagulation. So the fibrinolysis is part of that, wherein the body will try to break down the excess fibrin because of the clot formation. Now this will release the byproducts that can further disrupt the normal clotting. So it will be a vicious cycle. Your patient will end up bleeding. Okay? So at the same time, they're going to be clots and bleeding as well. Now, why not letter A? 44-year-old with a pulmonary embolism. Well, we know that fat embolism can really contribute to DIC, but not pulmonary embolism. What about letter C? 62-year-old undergoing hemodialysis 3 times a week. Well, for patients that are undergoing dialysis 3 times a week, they're not primarily susceptible to the DIC. And for letter D, 34-year-old pregnant with placenta previa, this will not typically lead to the DIC. What we know of are actually those conditions that can lead to the DIC are the abruptio placenta, not placenta previa. Abruptio, placenta, and also septic abortion. So these are known to cause DIC, not placenta previa. So please review those important concepts. Now this time, let's proceed to number 14. We're almost through. When assessing a client with lymphoma 9 days post-chemotherapy, the nurse should check for which symptoms due to the risk of septic shock. A, low-grade fever, chills, and rapid heartbeat. B, high fever, normal blood pressure, and faster breathing. C, flushed appearance, decreased oxygen levels, and mild low blood pressure. And D, elevated temperature, reduced urine output, and low blood pressure. Your patient here with lymphoma 9 days after chemotherapy. So what are those symptoms that you should be looking out in case they have that septic shock? What are these symptoms? Your answer should be what? Take a look into the time frame here. When assessing a client with lymphoma 9 days post chemotherapy. Your answer here should be letter A. Low-grade fever, chills, and rapid heartbeat. That's the tachycardia. Okay? These are early signs of septic shock, which is going to likely happen 9 days after the chemotherapy. They're going to be immunocompromised. All right? Why not letter B? High fever, normal blood pressure, and faster breathing. Well, we know that high fever, increased respiratory rate, can indicate infection. But take a look into the normal blood pressure. This is making the statement incorrect. Normal blood pressure. Right? The faster breathing alone is not going to give us that inkling. Now, what about letter C? Flushed appearance. Yeah, we know about the flushed appearance, right? Early sign of sepsis. However, looking into the decreased O2 levels, mild low blood pressure, look into the contrast here. We know that there is the massive vasodilation. That's why there is that early vasodilation that will make the skin have that reddish appearance. So there's going to be that flushed appearance. But look into the decreased oxygen levels. This is not a sign of early septic shock. So this makes the option incorrect. Now for letter D, elevated temperature, reduced urine output, and low blood pressure. These are not typical early signs, but these are later signs of septic shock. Take note about the differences here. So again, your task in this test question is to contrast the early and the later signs of septic shock, especially in this patient with lymphoma post-chemotherapy. Let's have our number 15. A nurse assesses a client newly admitted with acute pyelonephritis. Which findings should the nurse prioritize reporting to the healthcare provider? A. Temperature of 100.1 degrees Fahrenheit or 37.8 degrees Celsius, blood pressure of 89/47 mmHg, C. Cloudy, foul-smelling urine, and D. Complaints of flank pain. What findings you should notify to the doctor? The correct answer here will be letter B, the low blood pressure. It's suggesting that the patient is possibly in urosepsis or septic shock. You need to intervene into this patient. Okay, so I want you to calculate the MAP on this one as well. Doing it yourself, please. Now, how does the pyelonephritis cause urosepsis? That's the question. Well, in the case of urosepsis, remember that when there is presence of infection, the bacteria can actually cause the toxin to spread into the bloodstream, because we know that the kidneys are actually highly vascular. If there is possibly, if there is that infection, pyelonephritis, there's inflammation of the tissue. There's also permeability, increasing permeability of the blood vessels. This can allow those bacteria and also the toxins to be released into the bloodstream. And we know that the body's response is to release those pro-inflammatory cytokines, right? Those chemicals, the inflammatory substances. Once these inflammatory substances are released into the bloodstream, this can trigger the widespread inflammatory response we call as SIRS. So your patient will end up with the blood pressure getting lower. Your patient's blood cell count, white blood cell, will be elevated. There's going to be tachycardia as well. Now, why not letter A, temperature of 100.1 or 37.8 degrees Celsius? Because here, this is a typical sign of pyelonephritis, but not as urgent as the hypotension. Compare the two. We're talking about the perfusion again, the circulatory issue. 89/47. Remember about the MAP? Is that the MAP, guys? 61? Okay, wonderful. Thank you for doing that. This is very critical. Now, your patient that has a foul-smelling urine, cloudy, again, this is a common issue, common finding. It is expected in pyelonephritis. It's not going to call for an urgent intervention. If you selected letter D, complaints of flank pain, this is also an expected manifestation of pyelonephritis. It will not really call for an urgent notification compared to our hypotension. Gotta prioritize the circulation issue. Follow the ABCs: airway, breathing, circulation. The case falls under the circulation issue. Prioritize that one. All right. Now let's have our number 16. Let's do this. The scenario states the nurse is monitoring a 55-year-old female client following a total abdominal hysterectomy, salpingo-oophorectomy. Identify which of the client's assessment findings require immediate follow-up. Okay, so we have our patient's assessment findings at 11:30 according to the nurse's notes. Vital signs: temperature 101.5, heart rate 108, respiratory rate 20, blood pressure of 86/52, O2 saturation 94, in room air, and pain level, a surgical site at 5 out of 10. The respiratory manifestations here, we have clear lungs, no shortness of breath, cardiac sounds S1, S2 are present, capillary refill of 4 seconds. We also have palpable pulses in all extremities, no edema, neurologic, restless, agitated, states that gadget noise is keeping me awake while gesturing toward IV pump. Patient is oriented to person and place, follows commands per la, strength equal in hands and feet. Gastrointestinal hypoactive bowel sounds in all 4 quadrants. Genitourinary, voiding small amounts using a bedpan. Skin warm, dry, abdominal incision covered with dressing, saturated with serosanguinous fluid. Incision site shows inflammation with a foul odor. And 2 peripheral IVs, 1 saline lock, and 1 line infusing normal saline at 75 mL per hour. So, for each client findings listed below, identify whether it aligns with the condition of pain, delirium, or infection. So, these are the client findings. Surgical site drainage has a foul odor, cap refill of 4 seconds, restlessness and agitation. We got the temperature, heart rate, blood pressure values, and disorientation to time and event. So again, you're gonna associate these clinical findings to the 3 conditions. All right, so let's take a look into the surgical site. Drainage has a foul odor. You think this is going to be seen in an infection or a delirium? Or will this be seen in simply pain? Or, yeah, okay. Well, infection, this is a direct finding of infection. This is a manifestation that is associated to the infection. There is foul smelling odor at the surgical site. This simply means that there is bacterial contamination. All right, take note of that. It means that there is a localized infection in or around the infection. Okay. Now, for the delirium, we know that maybe it can be triggered by the infection, but it does not directly cause the drainage issues, nor it can cause a change in the odor. So we're not going to select the pain as well because it does not typically cause changes to the surgical site drainage, nor it will not cause the foul smell. All right. Next, we have the cap refill, which is going to be associated to the infection, because in cases of severe infection or sepsis, the capillary refill is going to be much more prolonged, right? Because of the decreased blood flow to the peripheral sites, because of the decreased circulation, which is also associated with a hypotension. But it's not going to be directly associated with a delirium, okay? Now we have restlessness and agitation. This is directly associated with the infection, particularly if it's progressing to the sepsis. We know that it can lead to the systemic effects, right? And often because they're going to have fever or discomfort. Now, well, in a delirium case, it can also be associated, right? There's going to be restlessness and agitation as part of an acute confusional state, which is commonly triggered by underlying infections. Now, what about the pain? Yes, it's going to be associated as well because of the discomfort, but would not necessarily cause the other cognitive changes. But yeah, it's closely associated. Restlessness, agitation will be common in pain. Now, let's talk about the temperature. You think that this is going to be closely associated with the infection? Yeah, we know. Fever, right? Tachycardia, and also the hypotension, closely associated. What about delirium? Well, we know that delirium itself will not cause any fever or changes in the blood pressure. It may arise from an infection causing the symptoms, but not really the other way around. Now, for the pain, it might generally cause an increase in the blood pressure, not hypotension. Okay, so this is not going to be applicable to the pain. Now let's take a look into the disorientation to time and events. All right, well, for an infection, that is correct, because with severe infection, especially in sepsis, this can lead to altered mental status, also confusion. This is a sign that there's already sepsis, right? Now for delirium, this is what we define as the sudden mental confusion and also disorientation. It can be fluctuating, so it can be associated with other underlying issues. Now for the pain, does not typically going to lead to cognitive disorientation as well. All right, so the only answer for the disorientation to time and events will be the, oh, here you go, the delirium as well, but not the pain. Oops, sorry. I quickly shifted slides. So review your answers. For the surgical site drainage foul odor, it's going to be closely associated with infection. Cap refill of 4 seconds, it's associated with infection. Restlessness and agitation can be associated with a 3, whereas the temperature, heart rate, BP of the following values is closely associated alone with infection. And lastly, disorientation to time and events can be tied with both delirium and infection, not pain. Let's have our next item. So basically, this is the same case. Now, your task here is to finish the sentence below by choosing from the options provided. So the statement here is, the nurse notifies the healthcare provider on client findings and recommends orders for blank and blank. So you have the box down here as your main source of your options between the two blanks. Okay, so what will be your answer for the first blank and the second blank? The nurse notifies the healthcare provider on client findings and recommends orders for. What do you think? The correct answers are the following. Serum lactate levels. This is a huge part in recognizing, identifying the patient's sepsis, right? What is the serum lactate level normally? Normally, the serum lactate level should be, let me change my pen. It should be less than 2 milliosmoles per liter. This is the normal value for the lactate, serum lactate. I want you to recall what lactic acid is all about. Remember, whenever there is a poor oxygenation to the tissues, or let's say hypoperfusion, decreased blood flow to the distal tissues, what's going to happen here is that with the lack of oxygen, this will lead to the anaerobic metabolism, right? Because of the hypoxia, this can generate the lactic acid. So if there is elevation of lactic acid, let's say 2 or 4, this is already considered as hyperlactatemia. If you're going to see a patient that has probably greater than 4 mmol, this is considered as severe lactic acidosis. So these are significant ranges, right? Greater than 4, it's already considered severe form of lactic acidosis. Now, the other blank should be wound and culture. Why? Because you need to identify the pathogen that is present at the surgical site. Take note about the localized infection. You need to know what's possibly causing, what specific microorganism is in there. So when you collected this culture from the wound, this will help us determine the appropriate or the specific microorganism so that the medical provider will be able to identify the most appropriate antibiotic to treat that infection. Okay, so that we can manage this patient's infection properly. Now, why not vital signs? We know that vital signs monitoring is very important in overall assessment, but with this patient specific issue, it doesn't really give us a much more of a value compared to the other answers that we have: serum lactate levels and wound culture. Okay, the vital signs are already known, right? Our patient has been hypotensive. They already have tachycardia, which are already suggesting sepsis. But what we need to know more about will be the lactate levels and the culture, which is going to confirm the diagnosis, and this will also guide the treatment. Now, why not KUB, kidney ureter bladder X-ray? This is a diagnostic test that will be needed to assess if there is any intestinal obstructions or maybe problems in the genitourinary tract, maybe kidney stones. But this is not really gonna support much with what is going on. It will not really help much as to the urgency in the treatment, right? Now, why not neurology consultation? Well, the patient that we have is displaying restlessness, right? Agitation. Those are actually concerns. These are related to the sepsis. But neurology consultation is much more appropriate when you have an underlying cause, maybe an altered mental status, okay? So it's not really going to be an immediate priority this time. Now, why not IV fluids? We know that the administration of IV fluids this time is very important in managing the hypotension, which we will be using to improve the perfusion in a septic patient. But what we're actually looking for this in this question is to look for those diagnostic information, which will focus on identifying the cause of the infection. All right, this is what we are looking for in this test question. Why not ABGs? We have the ABGs right here. We know that the arterial blood gases can provide information about the oxygenation and also acid-base imbalances. But the patient's assessment finding shows no significant respiratory distress or any. Do we have oxygenation issues right here in our scenario? It's not reflecting that. The patient's respiratory status, 20 breaths per minute in their respirations. Okay. It's not really targeting of what we are looking for. And serum electrolyte levels, we know that these are also important in assessing the metabolic function. But in this specific situation, there are no evident signs of electrolyte imbalance or any other cardiac issue. So this is going to be a less critical option compared to the identification of the lactate level and also the identification of the microorganism. All right. All righty. Wonderful, Linder. Let's have our next question. The same patient. Which of the following nursing interventions should the nurse include in the care plan? Select all that apply. Start a crystalloid fluid bolus at 30 mL per kilo. Get ready for an urgent transfer to the surgical department. Obtain blood samples to measure serum lactate levels. Administer broad spectrum antibiotic therapy. Provide supplemental oxygen adjusting to maintain an SpO2 of 94 or higher. Confirm the client has at least 2 functioning IV access points. Draw labs to evaluate renal function. And lastly, prepare for potential endotracheal intubation. So which of these interventions should you include in the care plan? The answer should be the following. You should start, or you should include starting the administration of a crystalloid bolus at 30 mL per kilo. We know that our patient is in sepsis. This can cause hypotension and poor tissue perfusion. So our fluid administration here is based on the body weight, which is part of an evidence-based guideline to improve the circulation, and also it will improve the blood pressure. Okay, and we know that the fluid resuscitation is really important to maintain the perfusion. Remember about the MAP. Okay, we need to keep that in a very safe range to prevent multi-organ failure. All right. Now, what else? You think getting ready for an urgent transfer to the surgical department is appropriate? Do you think that will do? You think this is going to be part of your care plan? Well, there is no indication that this is a surgical emergency. There is no finding that our patient is bleeding, or maybe there is wound dehiscence that may require urgent surgical intervention. It's not. So we are not going to include that. What about obtain blood samples to measure serum lactate levels? Do you think that's part of it? You think so? Yeah, of course. You gotta include that in your care plan. We need to assess if there is severity in the anaerobic metabolism, especially if they're gonna have some form of hypoperfusion. All right, we need to make sure we have that value. Now, what about administer broad spectrum antibiotic therapy? Do you think that this, oh, here we go. I forgot to mention about the blood samples. Obtain blood samples to measure serum lactate levels. Oh yeah, that's it. I thought this was a blood culture. Administer broad spectrum antibiotic therapy. Do you think this is appropriate as part of the care plan? Yes, of course. When your patient is in sepsis, we need to treat the infection right away. But before that, you have to consider making sure that there is drawing of the blood culture so that we will know the specific microorganism. What about provide supplemental oxygen adjusting to maintain SpO2 of 94 or greater? That's part of your care plan. We're talking about care plan, nursing actions that should be included in the care plan. Yeah, of course. Your patient possibly will end up with hypoxemia. You need to make sure that the body is able to supply oxygen to the major organs and also the distal body parts. All right, what about confirm the client has at least 2 functioning IV access points? IV access? Yes, it's very important, especially if your patient has sepsis, so we can administer readily those treatments, antibiotics, vasopressors, which will help stabilize the kidney function is important, like your creatinine. I hope that I'm still visible in your screen. Looks like I have a fluctuating screen right now. So that's going to be part of your care plan. And lastly, prepare for potential endotracheal intubation. That's not going to be part of your care plan. You is in respiratory distress this time? No, there's no reports that they're struggling to catch their breath, nothing like that. So we will think about this when the patient will progress into that stage, but not this time. All right? Intubation is not indicated in this scenario. So what you should focus on will be managing infection. You're going to have to treat the hypotension with fluids and also making sure that you have the diagnostic data, lactate, antibiotic, what else? Administration of crystalloid bolus, IV, of course, and assessing the renal function, as we are going to take note if our patient's kidney function is still okay, if we are giving them the antibiotics, and also with the hypoperfusion, we need to know if the kidneys are getting enough oxygen as well, and blood flow. Let's have our last item. The nurse reviews assessment findings for a 55-year-old client who was diagnosed with sepsis following a total abdominal hysterectomy, salpingo-oophorectomy 4 days ago. Which of the following findings suggests the client is stable enough for transfer to a lower acuity care unit? Select all that apply. Heart rate of 88 beats per minute, white blood cell count of 16,000 per cubic millimeter, hemoglobin level of 14 grams per DL, Glasgow Coma Scale of 11, serum creatinine level of 3.6 milligrams per DL, mean arterial pressure of 70, urine output of 45 mLs in 4 hours. So, which of these findings can safely suggest that your patient is stable enough to be moved down to a lower acuity care unit from, let's say, a critical care or ICU? So what do you think? The following answers are heart rate of 88 beats per minute. This is in the safe range. Remember about that, one of the criteria here is the heart rate. Anything above 90 beats per minute actually will qualify as part of the sepsis, right? Our patient's heart rate of 88 is within the normal range, very normal. So it indicates that the heart is functioning well, no signs of tachycardia, no bradycardia, no instability. And so this is demonstrating that our patient is having adequate cardiovascular stability. So there is possibly sufficient cardiac output this time. Now, what else? That's going to be the MAP of 70. Okay, this is generally considered minimum level to ensure that our body organs or the patient's body organs can receive the adequate blood flow and oxygen as well. So this indicates that the patient's circulation is able to maintain that perfusion, right? Yeah. Why not white blood cell count of 16,000? That is still high, right? It is still elevated, and this is signifying that there is an active infection or inflammation. So the body is still responding to a stressor. So not really an indicator that this patient is ready. MAP is borderline. 70 generally considered as normal. 70. Yes. Okay. Why not hemoglobin of 14? Hemoglobin of 14. Does it reflect anything significant? It's within the normal range, right? It doesn't really reflect any disturbance here. So we're going to eliminate that one. And the Glasgow Coma Scale, I mean, hemoglobin level of 14. It's not really going to reflect the stability of our patient for the blood pressure or circulation. It doesn't really have that direct association, I should say. Yeah, we know that hemoglobin is going to be closely associated with, let's say, perfusion, oxygenation. But in this case, it's not going to be a direct measure of how well the body is able to maintain the perfusion, which is much more closely related to the blood pressure and also the heart rate. Now, what about the Glasgow Coma Scale of 11? This is low, right? It reflects alteration in their consciousness. So this could indicate instability in their neurofunction. So this will be inappropriate to transfer. I mean, not a good sign that the patient will be transferred to a lower level of care, especially that they still have the sepsis. Now, what about the creatinine level of 3.6? This is elevated, right? Elevated. Look into the creatinine of 3.6. This is a possible sign that there is kidney impairment or acute kidney injury. Could be a sign of existing renal condition as well. So your patient probably is not effectively treating those waste products still. So not a good indicator that they're going to be transferred safely, right? It's high, 3.6. Now let's have urine output of 45 mLs in 4 hours. This is very low. Remember, of our minimum output hourly is 30 mLs per hour. It is suggesting that our patient has impaired kidney function and also poor tissue perfusion. So this is a significant finding. This is not an indicator that your patient is safe to go to a lower level of care. All right. With the kind of surgery she had, how come hemoglobin level is not significant? If you're gonna, take a look into the hemoglobin of 14. Remember, our patient is a female, right? We know that this is within the normal range. No doubt about it. This is within the normal range. But what the question is really asking you about is asking you once again those certain criteria for the sepsis, right? Look back into the temperature, the blood pressure, the heart rate, the lactate, the urine output. Look back on those. The hemoglobin, or could be red blood cell, whatever you're thinking right now, those are not part of the criteria, even though they're going to be significant as well. But then again, these are not direct indicators that our patient's sepsis is resolving. Okay? These are not direct indicators about the sepsis. I totally understand about your how you're thinking about the surgical procedure, that possibly that they have blood loss and maybe their hemoglobin level is within the range, which is a good outcome, right? But then again, it is not a direct indicator that their sepsis is resolving. That's the end point here. So that is why we're going to have to go back into the criterion, the lactate level, the blood pressure, the heart rate, and also the temperature, the kidney function, renal output, or the urinary output, that is a minimum of 30 mLs per hour up to 50 mLs per hour. So I hope that you are learning from this one. These are difficult questions, and you really need to think about the fundamentals of nursing, med surg on here, also part of women's health. Everything is so condensed in this scenario. These are difficult questions, no joke. So I hope that you're learning from all these different cases, and this is the end of our Q&A for today. And so we are actually wrapping up the end of our 90-day free NCLEX review series. So we are extending our heartfelt thank you to everyone for your incredible support and also your commitment to attending these sessions. And we do appreciate your attendance, your engagement. You really made this journey truly rewarding. 90 days, imagine that. And we had that significant pause as well. So we hope that the reviews that we offered you have been so valuable in your exam preparation. And don't forget to stay connected, even though probably you're not going to see me right away, after the session, but keep posted. We will be continuing sharing some nursing content and also helpful resources in this channel. So keep posted. Make sure that you have the notification bell clicked for all updates. So keep an eye for future updates, and we are also excited to keep this journey with you. So keep learning. All right. Well, I thank you for your time. And again, you all take care and see you in the future. Appreciate it. Bye-bye.